Thank you very much, sir, for this very informative talk. Now I invite Professor Daniel CASSUTO from Italy to share his approach.
Thank you very much. And meanwhile, I think there was a little misunderstanding while Matt was injecting. What Sahar meant to ask is, when do you do anesthesia? She was not questioning the fact that you were illustrating it. And then at the end you answered it, and everybody answered it already. In fact, the subject after Sebastian has given the anatomical explanation in such a beautiful way. One thing I wanted to remind, and I have no conflict of interest with Merz, I have worked with them in the past and I have nothing to do with them today, is that there's another tool that is quite useful to handle hand rejuvenation, which is a validated scale they've published, and you can see the description here. It's quite good in order, especially for beginners. Once you're used to do this and you get the eye, then you don't need it. It's also very good sometimes to show patients the results. The results in hand rejuvenation are so natural, usually, that sometimes it's difficult for patients to appreciate them, especially long term. And so when you can confront the actual hand with the validated scale and show them that there is some kind of improvement even with an objective tool, it helps patients' communication, which is always very important. I have found more techniques than Sebastian has mentioned, and it doesn't mean that I like any of them, even the one you didn't mention. And I think that, as in everything, there was a big learning curve, especially in the last decade, where only surgeons used cannulas for fat grafting, and the medical world did not use cannulas, and tried to be as ingenious as possible to inject the hands with needles. I think that today the hand is one where there is a general consensus about using cannulas. Anyway, these are some of the techniques that were used. I think the most hilarious today is this one, where they put a bolus in the dorsum of the hand, and then they instruct patients to sit on the hands for 10 minutes instead of wasting time molding or massaging it. But this is just a curious way. My favorite way is obviously entering only the superficial fatty lamina, and this has been published already a few years ago, and I think that it's very important that Sebastian showed you that beautiful dissection. I have now another question for Matt. I hope you don't get angry at this one, but why do you use two entry points? In my humble hands, one entry point with the cannula is more than enough. And basically, it's from the same entry point. This is the order I use. However, here in this area, where, for those who know, the famous snuff boxes, I usually make another little fan. And anyway, with just 0.2 aliquots in each interosseous space, I'm quite well. And the question is, which filler? And now I'm going back to what Pierre was showing. I think that since every one of us makes a lot of mistakes, I don't think morally and ethically we should use anything that is not reversible. I'm not saying that calcium hydroxylapatite and polylactic acid and all the other fillers, I'm not saying they're not good. For those poor countries who have nothing better, then, let them use what they have. But I think that if you have something reversible and dissolvable very easily, I think it's our ethical duty to use it, because we can never assure our patients that we'll never make a mistake. We cannot guarantee that, but we can guarantee that we can make mistakes that we can solve with relative ease. Now, which hyaluronic acid? Very practically, this is not scientific, but do a snap test. If you have an old man like me and you see that the skin doesn't snap back into place, then you want to use one of the low G prime, softer, more cohesive hyaluronic acids. When you have a thicker hand or a skin that is not as old as mine, then you can use a higher G prime, less cohesive filler, because it will be easier for the skin to hide it and you're not risking any tyndall effect. I've seen some overfilled hands, both with, unfortunately, polyacrylamide gels and some very thick gels for those who know macrolane. And then you see these horrible tyndall effects in old people. This was achieved just in order to have a longer lasting effect. Which brings me to Pierre's presentation again. Oh yeah, one thing I forgot. If you have solar lentiginous, please remove them with some good Q-switch laser or any peel or anything you're good at. Don't forget that this is as important as the filling. Okay. Just 1 second. Sorry. Okay, I've inserted here two other slides, but the changes, I probably forgot to change, to save the changes, so I'm going to say it by heart. I've already presented yesterday just a few articles. There's plenty in the literature that show that hyaluronic acid as a molecule does have a very important stimulatory effect, which is not mediated by inflammation. It's mediated by the CD44 receptors that are common to all mesenchymal cells. That means adipocytes, fibroblasts, melanocytes, chondrocytes, osteocytes. That's why it's used so much in orthopedic surgery. And that is definitely anti-inflammatory. That has been published, there's been evidence about this in the literature for at least 10 years in the basic sciences and in the orthopedic surgery. So I don't understand why some people, you are quoting people who are putting hyaluronic acid in the dummy space filling, non-stimulatory area, or maybe I misunderstood you and I'd like you to clarify at the end of this. Hyaluronic acid, besides being safer because we can dissolve it, is also actually a normalizer. It's a modulator of cell activity. It also can normalize the activity of myofibroblastic keloids, etc. So this is why it does stimulate without causing inflammation, without causing a granulomatous or foreign body reaction, unless bacteria get in the way, but that's another story, that's a complication. So these are some, all the results you see are at 1 year without repeating the injection. And you definitely see an improvement in hand quality, even in cases that were not injected, that were not treated with a laser. I think it's a very, very easy treatment to do, provided you use a large cannula enough, as Raul was saying about fat. Here we use smaller cannulas than with fat grafting, but they have to be blunt and around 22, 23 G, not smaller. Many people have the misperception that smaller cannulas can hurt less. This is exactly the opposite. Larger cannulas are blunt and push away tissues instead of piercing through them. It's also much more difficult, not impossible, to damage a vessel or a nerve with a blunt-tip cannula that is 22, 23 G. Unless, and this is another difference I'd like to point out, the movement we should do is exactly what I showed in the animation. Just go in once and inject retrograde. Those dissection movements that you see doing, for example, for fat grafting, should definitely not be used when injecting hyaluronic acid. They're not needed. The loose areolar connective tissue that we have in the superficial fatty lamina will allow for good diffusion of any hyaluronic acid filler you inject there, even without massaging too much. But especially if you inject those fine threads in above the interosseous spaces, then there's no more need for manipulation. However, with any tool you use, any cannula you use, if you do those quick, violent, undermining movements, you may end up, as Sebastian said, losing your plan, going down from the superficial fatty lamina into the mid one, where all the vessels and nerves are. So unless you're doing fat grafting in a surgical facility, don't do those movements. When you're just injecting a filler in your office with a cannula, just go in and out very, very smoothly. I'm not saying you won't have any problems, but you're minimizing the chances. Thank you very, very much for your attention.